Good afternoon, everybody. I'm Dr. Priyadarshini Raghunathan, and today we'll be discussing about opioid-free anesthesia. This is a very new and upcoming topic in the field of anesthesia. So, what is opioid-free anesthesia? It is a technique where there is no systemic neuraxial or intracapillary opioid that is used in the patient during the surgery. So, opioid-free anesthesia is like one end of the spectrum. A slight variant of it is opioid-sparing anesthesia. In opioid-sparing anesthesia, we try to limit the amount of opioids that we are giving to a patient by giving him the multimodal anesthesia regimen. So before we talk about opioid-free techniques, we'll first see why opioids hold the current place that they have in the field of anesthesia. So one is because of their hemodynamic stability that they give. So we all know that when compared to other induction agents, having opioids are very hemodynamically stable. The cardiostable potential of the opioids is very high. Also, the analgesic potency of opioids is very proven to be superior. So you can see in the WHO pain ladder also, for step 3 or severe pain, the drug of choice is definitely a strong opioid. So when coming to opioid-free anesthesia, so we have to replace the hemodynamic stability that opioid is giving. We have to replace the potent analgesic property that opioid is giving us. So before we talk about how we are going to do that, let's talk a little bit about the mechanism of action of opioids so that we know how all we can replace this with a different drug. So opioids act by G protein coupled receptors. These receptors are located everywhere in the brain and the spinal cord. In the brain, especially located in the periaqueductal gray matter, locus coeruleus, and the ventral medulla. In the spinal cord, it's located in the substantia gelatinosa of the dorsal horn of the spinal cord. The receptors, we all know, are mu, kappa, and delta. The current nomenclature has been changed from mu, kappa, and delta to MOP, KOP, and DOP. This I just put it here for your information. So, slight look on the pain pathways. You can see here from the peripheral nerve endings, the first order neurons come. They reach the dorsal horn of the spinal cord, and from the dorsal horn of the the dorsal horn of spinal cord. From the dorsal horn of spinal cord, they arise in the spinothalamic tract of the thalamus, and from the thalamus, the third order neurons go to the somatosensory cortex. So opioid receptors are located in all these regions. They're located in the spinal cord at the level of dorsal horn, supraspinal level, thalamic level, and in the midbrain. So how they act is in the central nervous system, the mu receptors which are present in the CNS, they activate the descending inhibitory pathways and they inhibit the pain outflow from the periaqueductal gray matter and the nucleus reticularis, gigantoreticularis. In the peripheral part, the opioids directly inhibit the peripheral nerve endings from getting stimulated, and also they inhibit the pain transmission at the level of dorsal horn of spinal cord. Together, this causes a decrease in pain transmission in the periphery. A small line about what are the mediators used in the pain transmission. So peripherally, the mediators that are used are substance P, bradykinin, histamine, and prostaglandin. We know this because this is the mechanism of action of NSAIDs because they inhibit prostaglandin synthesis. Centrally, among the mediators that play a role, two important mediators are glutamate and GABA, out of which glutamate is the most important because it's an excitatory neurotransmitter that is present in all the pain transmission of the nerve endings. So coming to the side effects, why we are moving away from opioids is because of the side effects of opioids. So if you see among the different side effects, the most concerning for us as anesthetists in the immediate postoperative period is the respiratory depression. So opioid receptors in the CNS increase the threshold of the respiratory system to carbon dioxide. So what this causes is it decreases the responsiveness of the respiratory centers to PCO2 levels. So a higher level of PCO2 is required for the patient to get stimulated to breathe normally. So this causes a shift in the right to the CO2 response curve. So respiratory depression is a profound side effect of opioids that we would like to avoid, especially in certain susceptible patients. Another important side effect that is worrisome in the postoperative period is the gastrointestinal side effect. So opioids decrease peristalsis, they cause nausea, and they cause vomiting. So these side effects are undesirable, especially when you want to fast track the patient towards the recovery. So when you want to start orals to the patient and want to discharge the patient, having a opioid-induced nausea and vomiting and constipation is a significant distress to the patient. Urinary retention, of course, opioid-induced urinary retention. Again, no patient is comfortable with a full bladder. And also, you cannot, if it's a daycare surgery, you will not be able to discharge the patient unless he has voided the bladder. And the most important side effect, that is dependence. So that has become the current epidemic, opioid epidemic in our field, is when chronic use of opioids has led to physical dependence. Dependence is nothing but a state of adaptation where the patient develops withdrawal syndromes on abrupt cessation of the drug or decreasing the dose of the drug. So, I think you all may be aware that there is a rising crisis of prescription opioid abuse. Not currently, it's not that much in our part of the world, but it's significantly impacted the Western world. And this has led to the change from opioid-based anesthesia to opioid-free anesthesia. You can see so many people are addicted to prescription-based opioids. Another significant side effect is opioid-induced hyperalgesia. So hyperalgesia itself, as the name indicates, means an increased perception of pain to a normal painful stimulus. So why this occurs is when chronic opioid consumption causes certain changes in the CNS, which is similar to a central sensitization. By sensitization means these receptors have become more easily activated to the same painful stimulus. So the amount of firing from these receptors will be more, and hence the patient will have more perception of pain when compared to the normal painful stimulus. So opioid-induced hyperalgesia is a significant side effect, especially it is seen more often with remifentanil and less with that of fentanyl. So coming to the shift towards opioid-free anesthesia. So what is happening is, initially we had only ether. So initially they were only doing an inhalational anesthesia. Slowly we developed muscle relaxants when tubercularine came into the picture. So slowly we shifted from inhalational anesthesia to slowly balanced general anesthesia, where opioids started getting administered. And once the potency of opioids were documented and were proven, it was eventually shifted to a completely opioid-based anesthesia. Now, concerned with the side effects of opioids and the addiction potential of opioids, now we are moving towards an opioid-free anesthesia, where intraoperatively we try to minimize the use of opioids, and postoperatively opioids are kept as a rescue analgesic for post-op analgesia. The future, we don't know. We may have an opioid-free as anesthesia and analgesia, OFAA. So what is OFAA? Is when the post-op analgesia also is given without opioids. It is just analgesic, non-opioid analgesic. It may be the, it is also something that is upcoming at present. So coming to opioid-free techniques. So what are the advantages of opioid-sparing techniques? Is mainly, of course, as discussed, the respiratory depression component is less PONV, less post-op ileus and constipation, and less immunosuppression. I will talk about the immunosuppression topic in a few slides. So now we talking. Now when you come to how to replace opioids. So what are we? How do we replace opioids? So we have to take care of three things. We have to take care of how to inhibit the peripheral nociception. We have to see how we can inhibit central nociception and how to maintain hemodynamic stability without opioids. So peripherally, when the nerve endings get stimulated and release the inflammatory mediators and cause the sensation of pain, instead of opioids, how else can we block it? This can be done by peripheral nerve blockades, like when you give a regional anesthesia blockade. You can use lignocaine infusions. Steroids have a role, like dexamethasone, and of course NSAID, because they decrease prostaglandin synthesis. Then how do you inhibit central nociception? So central perception of pain, how is it inhibited? What are the drugs that we can give? Here comes the role of NMDA antagonists and gabapentinoids. And of course, we know that opioids are extremely cardiostable. They help to decrease the sympathetic response to all the stressful aspects of the surgery. So how do we achieve the sympathetic blockade in the absence of opioids? This can be done by beta blockers, alpha-2 agonists, and magnesium sulfate. So this is the overview of how what are the drugs that we are using in our opioid sparing technique. Let's see about each of them in detail. Before that, because in the previous slide we discussed about how to inhibit peripheral nociception and how to inhibit central nociception. So just a couple of slides explaining why we are talking about that and how different drugs come into that play. So peripheral nociception is basically when there's a tissue injury or any kind